Hello, everyone, and welcome to the next installment on our series in emerging technologies. Today, we're going to be talking about moving from descriptive analytics in healthcare. I'm really excited about our panel today. They are the industry's best, in my opinion. No group that I know of has a better visibility into what's going on with military health. As in the way of introductions, I'm Paul Williams, Vice President of Solutions. I also have with me Dr. Liam Toth. Liam, do you
Hi.
want
Liam Toth. I am the current Chief Medical Information Officer for Coney Government Services. My past history was as a pediatrician, a general pediatrician, for about 15 years before I found myself gravitating back into the technology world. I ended up going back and getting a master's and additional fellowship in clinical informatics and patient-centered technologies, and then shifted into the Air Force Chief Medical Information Officer, and then the Chief Health Information Officer for the Air Force, providing a lot of the services, both for assisting in the routine health care as well as some of the operational needs. Thanks, Paul.
Thank you. We also have Dr. David Carnahan.
Hi, everybody. I'm David Carnahan, an internal medicine doc by training, and I was in the Air Force for 20 years, retired in 2018, and joined Amazon Web Services in 2019. While I was in the Air Force, we did everything from measurement, analytics, decision support, and building out enterprise-wide dashboards. So also, when you do all that work, you have your hands in the data a lot. So a lot of experience there, really enjoyed it, and have been working with the military health system in the VA while at Amazon Web Services since.
Oh, great. Thank you. And we also have Mr. Matt Quinn.
Hey, everybody. I'm Matt Quinn. I am the Science Director of TATRIC, the Telemedicine and Advanced Technology Research Center in Medical Research and Development Command, now part of Defense Health Agency. I have too many years of experience on, I guess, all sides of health technology, from startups in Silicon Valley to was the director of healthcare initiatives for the Federal Communications Commission. I was at the part of HHS. I was the senior advisor for HRSA on health technology, Agency for Healthcare Research and Quality. I worked at NIST on health technology standards, and I was the managing director for healthcare and life sciences at Intel Corporation. 20 years and 20 pounds ago, I was an Army engineer officer, and I use that experience every day and working with our incredible team here at TATRIC to approach our mission of automating casualty care. Glad to be here.
Oh, thanks. As you all can see, very impressive lineup of panelists today. Just a bit of housekeeping. So we're going to go through about 15 minutes of presentations. Each of our panelists will have a period of time to go over some of their experience with the analytics. Please put your comments and questions in chat. We ask that you don't enable audio or video while we're giving the presentation, so the focus can be on our panelists. Once we're done with the presentation, then we'll go into questions and answers, and we look forward to that collaboration. That being said, let's get started. We're going to turn it over to Dr. Toth. Oh, I apologize. I am going to give just a quick overview. So today we're going to talk about the goal of analytics. It's always been used to improve healthcare outcomes. To date, they've been woefully inadequate, and we've got some paths forward using a learning system. Not going to go into too many details. We're going to let the panelists dive in, and here we go. Dr. Toth.
Yeah, thanks, Paul. So, when we started talking about this, we just were talking about analytics, and really, I think fundamentally what we have to start looking at is how do we really utilize analytics to actually improve health? I mean, I think that's really the goal, as Paul pointed out. So what I think it's important is to start to get some sort of framework for what we're talking about. So this is a pretty common, you'll see this used in a lot of places of, this kind of march of the different types of analytics. And there's a lot of confusion around this. A lot of people really kind of halted at predictive analytics. But it is important to understand the spectrum a little bit, starting with, descriptive analytics is what we're traditionally looking at. This is those reports that we're so used to seeing. And it really just tells you what happened in the past, not really necessarily a lot of information that's gathered from that. It really is just data being kind of shown in different ways. And there was a desire to say, hey, we really need to use this data for something. Let's figure out why did this actually go the way that it went? And that started leading people into diagnostic analytics. And really what is important in this is that you can see that the complexity for that diagnostic analytics really does start to increase. I don't think this is linear. I think it's actually a huge jump oftentimes with the number of people and personnel that you have to get from descriptive analytics to get to diagnostic when you start talking about that root cause analysis, really getting into the data. And you do start to get some insights to that, but it also just tells you still kind of why did something happen in the past, not really telling you, well, what's going to happen in the future, leading a lot of people to really wanting to get into predictive analytics. And that's what will happen in the future. And so people started looking at, well, if I change this, what's going to happen? Starting to get into that insight and foresight pieces. Still a lot of guesswork involved and trying to figure out, did I even choose the right things in the diagnostic component as I move forward? And that leads finally to what people really want to have, which is this prescriptive analytics. How do I make outcomes happen? And I think the important part of this is really focused on the outcome for the first time since you started talking about descriptive analytics. All of a sudden you're saying, hey, now if I give you an outcome, how do I get there? How do I have data that tells me what can I change to get there? That's really that foresight piece. Now, why is this important now? I think that the biggest reason that this starts to become important now was first started about 15 years ago when everybody started adopting these things called electronic health records, because all of a sudden we got an onslaught of data and people didn't really know what to do with it. And we were stuck in descriptive analytics. So we got a lot more descriptive analytics and healthcare didn't really necessarily improve very much. Part of it is because it is just so hard to do additional work to get to diagnostic analytics. Are you willing to put in the effort? And really, is there a return on your investment that's sufficient for that? And then, of course, over the last 5 years or so, we've really seen this new explosion, which is, oh, you know what? Maybe we can use this data by applying this thing called AI. And so a lot of this new kind of look into how do we get towards prescriptive analytics is kind of pre-folded into that. So just really quickly, I want to tell you, like, what do you mean by these things? Try to solidify that a little bit. We'll get some better examples here in a minute, but if you go to the next slide real quick, this is what we're talking about. So in descriptive analytics, you say, hey, we know that the amount of time that it takes from when you get into the emergency room until when you see a doctor has an impact on an outcome. And so what is that thing? And so it'll come back and say, here's this thing. It takes you an hour and a half or 3 hours or 10 hours or whatever it is. You're like, okay, well, that's great. Why does it take so much time? Or why does another facility do better than this? Or, what is a national benchmark? And so you start looking at what are the factors that impact this? And so you have to look at things very specifically. You'll notice that this isn't like, tell me all the factors. This would generally historically be, well, does staffing impact my door-to-doc time? Probably reasonable to think so, but you'd have to research it, really figure out. And let's say you start to look at that and say, okay, well, knowing that staffing is an impact, I don't have enough nurses and that seems to have an impact on my door-to-doc time. What if I change my nursing ratio? What will happen? What do I think will happen in the future? That's also helpful. It helps predict a little bit. Prescriptive analytics, and I think that's the reason people kind of view it as this holy grail piece, is, hey, you know what I'd really like to know? I'd really like to know what factors will help keep our door-to-doc time below a national standard and improve our overall patient care outcomes. And potentially it could come back and say, here is your staffing model every day, every hour that will help you do that. And then you have to kind of start to tease that out and look at it and say, does that really match what we can facilitate? It used to be that trying to get to that prescriptive analytics piece, the complexity was so high, very few places could actually undertake that effort. There's a lot of big national research facilities that would be trying to do this or get grants just to have enough money and resources to be able to do that. So what we did start to see, though, is by applying some of these new tools to all this onslaught of data, something did happen. And if you go to the next slide, we can kind of see that the complexity didn't necessarily go up nearly as much as it has in the past. Maybe isn't flat as projected here, but it's really pretty good at being able to apply some of these new tools and reduce the complexity and move towards value. So there's a lot of pieces in this that we really have to get after, of looking at those outcomes that you're measuring and a process that's going to get you to where you want to go. And this is very difficult for organizations to kind of make that transition. If you go to the next slide, we're going to kind of see one of the problems that comes up is we get a lot more data and we have a propensity for sitting in descriptive analytics and say, I want to see the data, or I need data-driven decisions. And data-driven decisions generally just mean I'm looking at data. And that means you're generally stuck on that first slide of admiring problems. So what a lot of organizations do is their data folds increase. They never stop to think, do I have the right data? Am I utilizing that data to identify problems and start to look at potential processes? Or am I really trying to get after that prescriptive piece? Am I finally getting after solving problems by utilizing the right data in the right places and being able to have an organization that will utilize that appropriately? Now, obviously, this in a big healthcare system is oftentimes feels a little overwhelming. You often have to change the entire beast of culture to get after this. But I do think that Matt's got some great examples of how, given a very targeted, extremely important nature of operational medicine, how can we start to apply some of these things? So, Matt, over to you.
Hey, thank you much. So all of this makes a lot of sense. And we have an amazing amount of data today from electronic health records. In our context at Tatric, our focus is before the electronic health record, before the healthcare system in combat casualty care. Some would call it role one in the military health system, or even beyond, or even before that. And so how do we affect analytics in that domain? So widely appreciated, especially in Army Futures Command, in our warfighting functions, is something called the kill chain. There's a great book by a guy named Christian Ambrose called The Kill Chain. And really it talks about the need to use data and to not just admire the problems, but to put it into action, to see, understand, decide, act faster for overmatch against our near peer adversaries. That's going to be the decisive aspect of victory against those folks. Well, in MRDC, we're not about killing people, we're about helping people. And so we, with the help of General Talley and our commander, Colonel Jeremy Pamplin, and others, put together something called the survival chain. There's a publication out there in Military Review if you want to read a lot about this. But we took this to say we need to assess, decide, treat, resource, and synchronize for better outcomes, meaning optimal health, return to duty, evacuation, and survival. Those are what we're focused on. And especially with the dual challenges that we anticipate in near peer, what we call multi-domain operations or large-scale combat operations, of a large number of casualties and prolonged times well beyond the golden hour of getting patients from role one to role two through evac, et cetera. We really need to think about how we can collect data and use data. And so I said Tatric's mission is to automate aspects of combat casualty care. Next slide. And this really means, how do we progress up the AI stack from just having data and data that we trust? And so we just go to the EHR, right? The combat medic on the battlefield would just go to the EHR and see what's going on with their patient, right? No. And so a lot of Tatric's work is, how do we use cameras, and other sensing technologies to passively collect data to describe what's going on in casualty care, right? So first thing we need is a source of data, right? And a source of data that we trust. So once we have that data, and maybe we run it through some algorithms or we manually annotate it to see what goes on in casualty care, or in our case, we run lots and lots of simulated casualty care scenarios with partners all around the country, and with a group down in North Carolina called Ragged Edge that has hyper realistic scenarios with cut suits and all sorts of stuff. Once we have that data, we can see what's going on. Are medics doing what we train them to do? Given 10 medics in the same scenario, how do they come at it? Do they use March or do they take pieces out? What about senior medics versus, say, soft medics? Do they work the same way? We're just getting to understand some of those medical performance aspects. And we're also collecting and organizing enough data about casualty care that we can start training algorithms to do things like identify tourniquets, identify resources used, the actions of the medic, and the state of the patient, and is our goal. Instead of manually filling out forms or manually typing something into a bat doc, how much of that can we automate, right? And so that's the learn. Also, once we have that data and we move up the AI stack, we can start using that data to make decisions, to help guide medics on the right path for caring for that patient. And then if we trust things entirely and we have the edge computing and we have, a whole bunch of pieces in place, we can actually start to automate aspects of casualty care to increase capability and capacity both at the point of need but across the system. So what are some things that we can take off the plate of a medic who's trying to care for a mass cal and has to care for those patients for a long time? In other words, how do we allow machines to do what machines do best and allow humans to do what humans do best? And in a nutshell, you can't do that with retrospective reporting. That medic can't, ask for a report from the back office and get it in a few days to, on the best course of action. We need to put that data into action for them. And it really starts by moving up this chain. So I'm going to hand it over to David to provide another example of how we move from descriptive analytics into the future. And I'll be happy to answer questions about what we're doing later as well.
Fantastic. Thank you. And so what I would say is that, Paul mentioned earlier about the learning system, and we find that actually learning systems could be health, it could be finance, it could be any domain that you're interested in or involved in. But from my experience when I was in the military and built out a pop health portal, we were focused a lot on clinical care and trying to have the best outcomes possible. What I found is, just like Liam talked about, there's a lot of emphasis on reporting. We were responsible for all the measures around quality and safety. And what typically would happen is, leaders would show up and say, hey, this measure where we aren't performing as well as others of our peers, what is driving those results? And so you go from a measurement domain to the analytics domain. And generally what happens there is, you get your experts in there, they build out a model, usually starts with descriptive analytics. And then when you understand what the driving factors are, or the statistically significant factors are, you can then move to a predictive model. And that's typically what we did. And I'll share that in an example. And then, but when there's a shift from, you understand the factors, now you're trying to answer the question, well, how do we change these outcomes? How do we make an impact? And that's when you shift to decision support. But that shift from analytics to decision support really has a very significant collaborative factor. A lot of times analysts will say, this is what we need to do, and without really consulting much with the clinical teams. And so a lot of what they understand to be happening in the workflow isn't really captured completely with what's really happening. So I think having that collaboration between the clinical teams and the clinical leaders and the analytics teams and their expertise with data science, having that together really allows you to then focus in on what decision support alerts or interventions need to occur in real time. The other thing you notice is that data is different. Matt really brought this out. Depending on what domain you're talking about, when you're doing analytics, just like he said, you could take your time, you've got historical data, you can dig into it, find those factors. But when you're dealing with decision support, that's usually a near real-time sort of data flow. And so, when you start to make those considerations on what the intervention looks like, you then have to think about those sorts of things as you introduce them into the workflow. So next slide, please. And this slide is just a simple example. Back in 2010, we were approached by, at the time, TRICARE saying, hey, we need a readmissions measurement. It really wasn't anything on the market. We used a New England Journal of Medicine article study to kind of build out a model. We found 10 statistically significant factors based on the data that we had available. And when we looked at that, primary care follow-up or lack of primary care follow-up was really the big, thing that stuck out. It was like odds ratio of 2.5. So if you didn't have a follow-up with your primary care, you had a 2.5 times more likelihood of getting readmitted for, some reason. Then when you go to we went to the predictive model, we looked at factors that helped predict kind of a segment of the readmissions. We want to try to capture as much as we could, but you don't want to capture, a large amount of the admissions, because otherwise your intervention is almost impossible because you're applying it to everybody. So this whole selective populations to focus in on is a foreign concept to a lot of clinical teams. They want to treat everybody the same. But if you're going to use analytics to try to increase and improve your outcomes, you're going to have to focus on a subsegment of those folks that are at highest risk. So what we did is we built a registry that accounted for 40% of the readmissions and only 16% of admissions, and that allowed us to kind of use the scarce resources of a primary care follow-up wisely. And so then eventually we wanted to get to prescriptive. This never really happened, but what I would say is the ideal thing to do is, once you understand your predictive model and you met with your clinical team to find out, hey, can we build a registry that identifies individuals that are high risk, and then make sure that the team focuses on getting them a primary care follow-up in order to reduce the readmissions. You then want to think about, what is our intervention in terms of discharge plans. So we were thinking of these 3 particular kinds, where you have primary care follow-up alone, or home health with primary care follow-up, or just simply a medication reconciliation, based on kind of the type of patient that we're dealing with. And then you study that to determine what the comparative effectiveness of those different interventions would be. And that gets into more prescriptive, where you're applying a predictive model with an intervention signal to the clinicians, but you're also thinking about the patient's unique characteristics in terms of what their needs are. You're not just saying, one thing fits all. So this is kind of an example, I think, in healthcare. The problem is, we could dig into this, but do analytics teams consult with clinical teams to come up with a meaningful workflow interventions? Is there any kind of measurement once an intervention has happened to determine, is it effective? And on we could go with this. But there's a lot of potential whenever you look at clinical scenarios, readiness scenarios, and other types for healthcare to improve those outcomes. Over to you, Paul.
All right. Thank you. Okay, I'm going to ask a couple of questions of the panelists based on what they've talked about, and then I'm going to move on to the questions from the audience. So my first question is for Dr. Toth. You talked a lot about, and I'm going to go back to your slides. You talked a lot about different aspects and moving from descriptive to prescriptive. But one thing I thought about in this is not all of this is a technology problem, right? Can you talk a little bit about the balance of people versus processes versus technology in these each of these phases?
Yeah, it's actually one of my favorite topics because I think a lot of people have a tendency to dive straight towards technology without first really trying to identify what the problem they're trying to solve is. And so I think the first thing that I would say is you have to start focusing on outcomes. One thing that I didn't talk about a ton, but when we focus on outcomes, that's our gold standard for what we're trying to improve. When we talk about patient improvement, but a lot of times it's really difficult to study that stuff, or has been historically, and so people fell back into some of these process measures that don't always lead to the right outcomes. And so we started focusing on the wrong things. And in healthcare, and really specifically, because we've done that for so long, our leadership, our culture really within healthcare hasn't made the shift to ask the question that you really want answered first, and then let's go back and see how do we either collect that data, or do we already have that data. We still have a tendency to go, what data do we have, what insights can we get from it? And that doesn't answer you or move you towards a value stream. It moves you towards an answer to a question, and it ends up that oftentimes you solve problems that you don't even have, because you're never really focused on the problem. So I think that the biggest challenge in this is getting a culture at an organization, especially in healthcare, that says, "Hey, let's stop with the data for a minute. Let's move back to say, what's our goals? What are we trying to accomplish? And then let's go back and start to identify, do we have some of those things?" I know David had mentioned while he's doing that stuff that the move into that prescriptive piece was really difficult. And I would garnish, or even ask him, David, what was that challenge of moving it into, we found this thing that should work, but we never really got it to happen.
Yeah, there's a lot of things. One of the things that came up very quickly is clinicians would say, "Well, I don't agree with that. I don't agree with lack of primary care follow-up being an issue." And it wasn't that they had a good reason for that. It's just that they didn't agree with the concept. And we're like, well, this is what the data is telling you. It's, an odds ratio of 2.5 is not subtle. That is a big odds ratio. So I think what you'd say is, okay, let's agree to do a small, study to see, even if 100 patients, do we see a statistically significant result? So with some of that, folks that aren't trained from an epidemiological standpoint, that are pure, clinical, you have to kind of get them on side with that, because that can actually shut it down, especially if the person disagreeing is a clinical leader. So organizationally, it has to be that collaborative between the two. And sometimes you have to have even senior leaders to step in and say, we're going to move forward with this. So it's organizational behavior type stuff.
Hey, just a quick comment on that. This issue of culture and things that aren't the technology, it's really important. And in a former life, I was the product manager of Six Sigma for healthcare for GE Healthcare, GE Medical Systems at the time. And one of the key differences between what we were doing and what a lot of other folks were doing was trying to get the ability to analyze data into the hands of clinicians themselves and their clinical leadership rather than financial people. Because there's a huge difference when measurement and performance improvement is done for accountability reasons, turning it into the Joint Commission or turning it into CMS or turning it into somebody who's going to pay you or punish you or reward you, rather than if it's there for quality improvement, for self-improvement, right? And in the former, there's always problems with the data. There's always problems with the data no matter what. But in that former one, the focus is on that edge case of the woman with the mastectomy that I got one marked off because I couldn't do the, yada, yada, right? Whereas if it's for quality improvement, especially for benchmarking, then there's a real openness and awareness to really dive into those things, to ask, why did it happen? To predict, if I did these things, why did it happen? It's a cultural pull rather than a fight uphill, right? And the reason that we're doing this, the reason that the second that you say we're going to pay you based on this, or we're going to evaluate you based on this, it turns sideways. And the second that you say, all you have to do is choose a project or two that you're going to do and that you're going to focus on and that you're going to work with, your peers on, it's a whole different environment and culture. I mean, in hospital world, and the same could be applied probably in casualty care world, right? Where if we start recording training, if we start recording performance during casualty care and giving people coaching tips, then they're much more likely to do it than if it's pass fail and here's the gauntlet, right? Anyway, so
that's great. All right, thank you. So I'm going to move on to the next question, and we're going to start with Dr. Carnahan. So the last question was focused on identifying, hey, the fact that we're going to need people to help solve this problem is not just going to be technology. Can you tell us a little bit about some of the technologies that you may use to help along in this process? What are some of the current trends and thoughts on each of these phases?
Yeah, I think if you look at the reports, I love looking at these reports, like how much data is there going to be in 2030 and 2035. I mean, it's just, the tsunami of data coming at us. And then you take into account some of the things that Matt was talking about in terms of sensor data and stuff like that. You start to add that, it gets exponential. So it's, we're going to have to lean into AI, and there's a lot of things we could talk about with AI. I know the buzz is a lot around generative AI, which is exciting, but there's a lot of other AI, modalities that we will be using. But I do think there's all sorts of considerations around that. We could spend a whole thing on that, but yeah. So AI ML certainly is a big one. I think the sensors, the devices, all of that those are going to be big ones. Using AI to even potentially do a lot of the heavy lifting that data scientists have to do right now in terms of cleaning up data and transforming it into, forms and features that allow you to have really good AI models. So there's a lot more. I'm sure Matt and Liam could actually add a lot more, but I think the sensory type devices, bringing that in, I like the idea of passive and then using AI to actually help us cut through the magnitude of the data and the volume of data that we'll be dealing with in the future. So I'd start there.
Yeah, I'll only add to that. I mean, early on in my career with informatics, one of the things, natural language processing, became a big deal. And just the volume load of computing power that was required in 2018, 2019 was astronomical. It just wasn't a feasible option. And then some of this, Gen AI stuff started taking things that we couldn't previously use and are now able to kind of more real time turn it into something more usable. So the discrete data concept of now we don't always need discrete data. And I saw a comment about some of the passive listening opportunities that are out there, and certainly they've been out there for a couple of years, but I think we're starting to see where they're able to put data in the right places and create discrete areas out of non-discrete, but it's only going to increase the amount of data we're going to be able to look at. And with that, I think one of the challenges is going to be, how do we use that data? And I think it's back to the non-generative AI type of things, probably combined with generative AI, to start asking those real-time questions. What can I do with this patient that's going to improve their, systolic ejection fraction in 10 years? Like, that sounds like a crazy question for us to ask. But I think we're maybe not that far away from where we're going to have the data to be able to ask that question. And then I think the real challenge that starts to be is, what does that do to our healthcare force? Like, how do we change how we deliver care to be able to meet that new demand or that expectation, because it's still not perfect. It's still not the human touch of healthcare. It's still not the hands on the body healthcare that people still really need and desire. Certainly, we see plenty of evidence. I think radiology, for instance, pathology have for a while been able to utilize AI to augment the human condition in diagnostics. But that next step into predictive, or even the prescriptive, and the next step is that learning healthcare system where you start to get the reciprocation. That's where I think we're all trying to tilt our heads to say, what does that even look like right now?
Yeah, I'll just say that the technology that we need may not even be technology. It's really a focus on user-centered design, and I'm a huge in the intended context of use. So something might seem like a great idea, but we need iterations context of use. And the context of use on a battlefield is different than in another role of care. Colonel Pamplin, our commander, likes to say, if you can do it under a bush, you can do it anywhere. And so trying to do things like use a camera and microphone and actigraphy to sense when somebody puts on a tourniquet or when somebody does some other procedure. It's really hard under a bush, but we can export that and bring it to other places. And I just say that the whole point of this, other than improving outcomes, is to provide value to those users, right? To that combat medic who is our customer, who is trying to care for a bunch of casualties without the time that they need to make those decisions, and without the evac that's coming right away, probably. So how do we offload things, even if it's 10% or 20% or 15%? We shouldn't look at perfect in the way of better. And the pacing piece of this is trust. If we don't organize that information, make it usable in a way that facilitates real-time decision-making, or decision-making in the time that's necessary, it's not going to work. And so many of us use navigation tools like Waze or Google Maps or whatever, and there's an amazing amount of information from sensors and cars and feedback and people keying things in that all translates into turn left, turn right, go straight. Anything more than that, and I'm confused.
Yeah, I want to add something to this because I think the trust issue is really important, and it's going to be one of those that's earned over time. We all did start out with Google Maps and Waze. Back when it first started, there was probably the whole, the office where they drive into a lake or whatever situations. Yeah. But over time, the accuracy is kind of proven, and that trust is earned. And there was a clinical example where just the other day I was talking to a partner who is using AI to diagnose cancer. And so you like, oh my gosh, it's crazy. But there are things we can do to make this safe and trustworthy. And so what they've done is they've gone through the FDA regulations for software as a device. And what they've been doing is they propose to use this as a safety net, as a second read, not as a first read. And that, to me, is the way you win. Is you say, okay, I'm going to read the slides after the pathologist has already done it and made their diagnosis. And what we'll do is we'll bring potential false negatives up, to the clinician's vision to say, hey, you may have missed something here. You probably need to take another look at this one. And then if that turns into, oh yeah, I did miss that, this is cancer, then the safety factor of really catching something that wouldn't have been caught for much later shows you that this implementation of AI could be very, efficient and very beneficial for patients and for clinicians.
Yeah, absolutely. So the concept of a human in the loop, a human on the loop, or full automation. Some of the work that Tatrick did during COVID, we called virtual hospital, and it was in conjunction with FDA and device manufacturers. And one of the things about COVID is that you don't want to be in the room with the COVID patient to turn off a false alarm on a medical device or to make an adjustment on a ventilator, right? And unfortunately, a lot of the places that had ventilated patients didn't have clinicians who were great at running ventilators. And so how do we address that? Well, everybody said, "Oh, you make autonomous ventilators. It can just sense all the patient's conditions and it adjusts them right." How about we just start with something for which there was a emergency use authorization from FDA, which is remote control. And so imagine that there is a human in the loop that can see and can communicate with whoever is there to see that the device changed on their demand, and they can see the vitals and they can communicate with the person through telemedicine, but they're actually physically changing it rather than moving all the way there, because we don't quite trust it yet. That said, an outgrowth of that was guidance to industry by FDA on physiologic closed loop control. And what does that guidance talk about? It talks about sources of risk and mitigations of risk. And this largely came from trying to do this stuff in the real world, right? And thinking through what could possibly go wrong, contention for control of a remote control device, right? Multiple people trying to control it and the local person. And so that's the best way to look at these things is a risk-based framework. And that's the way that the FDA and other regulators look at it. And they're on your side. They're trying to advance these technologies, but do it in a safe and effective, trusted way.
All right. All great information. I want to get to one of the audience questions, and I'm afraid that's all the time that we'll have for. So Jason H. asked for, and this was directed toward Mr. Quinn, can you identify a platform performing these tasks? So measuring medics' activities, for example.
Yeah, well, Tatrick is working on this with a whole series of partners, and I'll say it's not just one thing. It's a project called AutoDoc, which is passive documentation or passive data collection to support automatic documentation. We just won a 2025 Disruptive Innovation Award for this, but it consists of sensors that work reliably and collect the data that we need in casualty care environments. It involves algorithms that have been trained to work in, weird poses of casualty care and in green and in tan and in smoke and in whatever, to identify things from those sensors, from video and audio, to identify, the actions of the medic, the resources used, and the state of the patient. And an edge computing platform, because remember that we're not connected to the cloud in casualty care generally, to run that thing. And then an output. So how do you communicate this, or how do you send it? So partnerships with BAT docs. A important piece of this, especially in government, is what environment do you use? So part of this project for Tatrick has been doing simulated casualty care, hundreds and hundreds and hundreds of runs, right? We've collected thousands of procedures, of activities of medics in a database. We can just put that in the MIP, right? No, we can't. We can put it in. So we've worked with AWS and MIT Lincoln Lab. They have a AWS platform called Agent Rapids that there was a precedent for them collecting wearable data from a training environment. So they said, yes, you can do that here. We built annotation tools there. And the other key thing of having a cloud environment to do this is that you can open it up to other transaction authority or commercial partners who have expertise in algorithm training and development, right? If it was relying on us and the government to train algorithms, it ain't happening, right? We need the expertise of the private sector competing with each other to do this well. And that really is the environment, the technology world that you need to do this kind of work. It doesn't exist in government yet, best as I can tell. So we've had to partner with a FFRDC again on that AWS platform. I think it's informing some of our DHIMS platforms, because we need to do this kind of work, but we're not quite there yet.
Awesome.
Did I
Thank
answer?
you. Oh yeah, I believe you did. And we're out of time. So thank you to all of our incredible panelists. It's very obvious that one, you are very knowledgeable in this arena, as well as you have an incredible passion for it as well. So thank you for showing up. Looking forward to the next one. And if you guys have follow-up questions, please reach out to us. Everybody here is excited about solving these problems. So,
I'm on
thank you,
LinkedIn.
everyone.
Just say hi.
Yep.
Take care.
All right.
Take care, everybody. Bye.